hopefully many of such lecture series. It is my pleasure to welcome everyone. My name is Professor Bonga Chiliza, and I'll be chairing today's session. And this has really been a collaboration of a number of colleagues, but I just wanted to particularly mention Dr. Basil Eneka, who's the head of neurosurgery at Inkosi Tuli. So maybe I can start by saying, Basil, please say a few words about your thoughts about why this is so important and why we're looking forward to today. Thanks.
Right, thank you, Professor Bonga Chiliza. Welcome everybody, good afternoon, and thank you for joining us this afternoon. And I'd like to start by acknowledging Professor Chiliza for spearheading this initiative and the Department of Psychiatry. I think this is quite important. I think as we're moving, I think the future of clinical medicine and research is collaboration, because we're all interconnected, and specifically most of us that are here we all treat the brain and are fascinated with disorders that affect the central nervous system. So I think it's quite appropriate that we start a series like this where we can share ideas, collaborate, and hopefully as well we can improve our improvement of clinical outcomes and surgical and research as well. So the idea I think behind this is to probably at some point take this series of lectures into something like a neuroscience collaboration, neuroscience institute, where we can all work together, investigating and researching disorders that affect the central nervous system. And I'm quite pleased that I see a lot of people have joined the first inaugural lecture, which I think is going to be very exciting. And I think it's a step forward towards a big, bright future, towards collaboration amongst our disciplines and other colleagues as well in other disciplines that share the same interests as us. So I welcome all of you, and thank you, Bonga, as well for spearheading this. And yeah, looking forward to it, and all the best to everybody that is part of this initiative. Thank you.
Yeah, no, thanks, Basil. So our first speaker is Dr. Lindor Taylor. Dr. Taylor is a neuropsychiatrist. He is the head of the clinical unit of psychiatry at King Edward Hospital. He is, I'm quite excited because Lindor is a son of the soil. He is from here. He studied as an undergraduate at this university in KwaZulu-Natal, did his postgraduate studies here, did a little bit of private practice, and really realized that he should be an academic. So he actually closed his private practice in Durban and he moved to UCT at the University of Cape Town, where he then spent 2 years studying with a guy called Professor John Joska, who many of us are aware is probably the eminent scholar when it comes to HIV and neuropsychiatry in our country. So he spent 2 years under his leadership, learning from him as much as possible. And we are really delighted that he could come back and join us to come back and then hopefully teach other people neuropsychiatry here in Durban. Apologies. So he'll be speaking on HIV neuropsychiatry and a little bit on why it's important to continue making sure that we treat our people very well on HIV neuropsychiatry. We really do encourage colleagues to please ask questions. Maybe just start as soon as you see a slide that he has spoken on, if there's any questions that you'd like to ask. We want this to be a collaboration, not just in research, so it doesn't have to necessarily be very interesting questions, but it could also be hopefully lead to a collaboration within clinical services and of course also within teaching. So any questions? No question is seem to be inferior to other questions. Please do ask. He's going to be talking about terms that may be a little bit new and not familiar to you. So please go ahead. Feel free to ask him questions. So thanks, Lindor. Over to you, please, sir, and let us, enjoy your lecture.
Thank you, Prof, for such a great introduction. Like Prof has said, my name is Lindor Taylor, and I would like to thank everyone for attending this session. So to begin our talk, I would like to just do a brief introduction of what neuropsychiatry is all about. So neuropsychiatry, also known as organic psychiatry, is a branch of medicine that deals with mental disorders attributed to disease of the nervous system. In South Africa, it is a subspecialist qualification. In clinical practice, our scope of practice includes managing neuropsychiatric disorders that emanate as a result of organic brain disease. Organic brain disease disorders could be anything from neurodevelopmental disorders, acquired disorders, and neurodegenerative disorders. An example of a neurodevelopmental disorder and a genetic, which is also a genetic disorder that can manifest neuropsychiatric symptoms, is trisomy 21, which is also called Down syndrome. These patients carry a gene of APP, which is amyloid precursor protein on chromosome 1. This increases the risk of developing Alzheimer's disease pathology. And these patients can develop Alzheimer's as early as the age of 21. Again, one of the neurodegenerative disorders in this case will be Alzheimer's dementia. An example of acquired brain disorders that we often see in clinical practice include infectious disease, traumatic brain injury, heavy metal exposures, metabolic and endocrine disorders. So to begin the talk, I would like to start by presenting a case vignette. This is actually not a real case vignette, but it's something that I created so that we could understand, so that I can just highlight to you what we're dealing with when it comes to HIV. So I'm presenting a case of Mr. X, a 50-year-old male living with HIV for the past 30 years. He's on FTC, which is a combination of lamivudine, tenofovir, and efavirenz at that time. He's been on this treatment for the past 25 years. He's virally suppressed with a normal CD4 count. Mr. X has been previously well and is an educator by profession. He's referred to us by his doctor for a second opinion regarding a complaint of progressively worsening neurocognitive function over the past 3 months. He reports that his cognitive fallouts are mainly in the domains of attention, concentration, working memory, and information processing speed. He reports that due to these difficulties, he's unable to complete his task on time, and his HOD has voiced his concerns. He denies any symptoms of other psychotic, denies any symptoms of depression, psychosis, or anxiety symptoms. He has no history of chronic medical disease, and has no history of TBI, and has no history of epilepsy. On assessment, our summary is that Mr. X has got cognitive impairment, which we classified as HIV-associated neurocognitive disorder. This is based on his clinical presentation, an IHDS score of 8, which is a screening tool, a bedside screening tool that we do in patients who present with cognitive fallout who are HIV positive, and a MOCA, which is a more detailed bedside tool for screening cognitive function. And on both these scales, it's got below the normal levels. For IHDS, the normal is 10, and for MOCA, anything above 26. We then did investigations. FBC was normal. His urea and electrolytes were normal. TSH was normal. B12 was normal. LFT was normal. CD4 count within the normal range. Plasma viral load below detectable. Syphilis was negative. CSF studies showed a slightly elevated lymphocytosis and proteins. but there were no viruses detected. The scan showed that it's got age-inappropriate generalized atrophy. So in this talk, I would like to discuss the following topics. I would like us to look at the HIV epidemic milestones of the past 40 years. I'd like to look at our progress as South Africa towards meeting the 1990 targets. I would like to look at us to focus on aging with HIV in the era of antiretroviral therapy. So in this, I'll focus on the life expectancy in people that are living with HIV, and to see if there's any evidence that HIV accelerates CNS aging. I'll also look at the HIV neuropsychiatric sequelae, and then look at the antiretroviral therapy-related brain injury or aging. And then we'll go back to Mr. K's case to see what is it that we could do for him, and then that will be the end of our talk. So with regards to the milestones, so I've included a slide just to highlight the progress towards eliminating HIV in the community, which everyone believes that can be eliminated via combination of antiretroviral therapy and by using vaccines, and the development of vaccines so far has not been very successful. So this is between 1980 and 2020. So we can see that there are some key developments that have been highlighted here on this on the slide. But what is interesting for us is that in 1996, that was the first time that triple therapy was introduced. So that was bringing some hope to patients who were infected with HIV, because that is more effective. And then, but only in 2015, governments decided that everyone should be on ARVs irrespective of their CD4 count. And there are implications to this, because by the time people were actually receiving the ARVs, most of the injury, especially in the brain, had already been done. And then in 2020, a World Health Organization came up with the concept of 1990 targets, which is about ensuring that 90% of people that are HIV positive know their status, 90% of that population are on ARVs, and 90% of those patients who are already on ARVs are virally suppressed. In the context of South Africa, which has also adopted the 1990 targets. So at the moment, according to this slide, which is taken from AVET, is what was published in 2020, South Africa has achieved 92% of testing. So 92% of patients that are HIV positive know their status. Of 90% of that 92%, 75% are accessing antiretroviral therapy. But unfortunately, that's just 70% of all people living with HIV in the country. And I think at the moment, we're looking at about 19% of our population living with HIV. That translates to about 7 million of our population. And of that 75%, 92% have achieved viral suppression. And that's unfortunately only 64% of the target of all people that are living with HIV. So we're far from achieving complete viral suppression in our community. So this is now trying to present how HIV gets into the brain. So this is a very simplified diagram trying to illustrate what happens to the brain with HIV infection. So what I've highlighted there is that there's a peripheral compartment that is completely separate from the CNS compartment by the blood-brain barrier. So how the HIV enters that uses macrophages to bypass the blood-brain barrier. Once in the CNS, the HIV virus infects the microglial cells and the astrocytes, and it doesn't necessarily infect the neurons. And with the infection, some of the things that happen, patients develop chronic immune activation and also a compromise of the blood-brain barrier. Some of the pathways that are involved are actually activated by the viral proteins, for example, the viral protein TET and the glycoprotein 120, and then it increases inflammatory markers as well. As a result of chronic immune activation, some of the mechanisms that happen is that in the CNS, there's increased glutamate production, and then the astrocytes do not recycle the glutamate. That often results in increased glutamate excitotoxicity, increased dopamine neuroexcitotoxicity, and this is often results in neuronal death. And other things that have been reported in brains of patients with HIV is that they tend to develop amyloid beta production, which is often seen in patients with neurodegenerative disorder, for example, Alzheimer's disease. These are proteins that are seen in patients with Alzheimer's, but in patients who are HIV positive, some scientists have observed that when they did biopsies or autopsies of patients that have died, they've identified amyloid beta plaques in their brains. So this is a slide that I actually copied from the internet. So it's very simplified. It says, it's from Science Daily, it says HIV infection, even with antiretroviral therapy, appears to the brain. I think this is a very important slide for us as psychiatrists or as neuroscientists or people that are involved in management of patients who have brain problems. Because what we know now is that HIV in the brain has the potential to replicate independently. This is often termed compartmentalization. The HIV virus in the CNS can adapt, and brain-specific mutations have been reported in nearly all genes of the virus. This means that ARVs or antiretroviral therapy that is effective against the plasma HIV may be ineffective in the CNS. The brain is also a relatively immune-privileged site, and the blood-brain barrier prevents easy access of the antiretroviral therapy. There is also evidence that HIV in the CNS could migrate back into the blood even after it was eradicated. So patients have been found to demonstrate some plasma blips, and the hypothesis is that these plasma blips are actually, they are coming from the CNS. In terms of going back to what the life expectancy now of HIV patients who are on ARVs. So we know now with sustained viral suppression and adherence to ART, the mortality rates of the mortality related to HIV, the sustained viral suppression and adherence to AR antiretroviral therapy reduces the mortality related to HIV. This is one of the great public health success stories since the HIV was identified. And when comparisons of life expectancies between people living with HIV versus those who were negative, they found that people living with HIV have life expectancies that are almost comparable to HIV negative people. In South Africa, the current life expectancy is around 64 years. Unfortunately, I think we all appreciate that with aging alone is an independent risk factor for neurodegenerative disorders. And on that, Johnson and his colleagues in 2013 decided to do an investigation of the life expectancy of patients who were starting ARVs. They found that life expectancies of patients with a baseline CD4 count of above 200 were between 70% and 80%, 86% of those in HIV negative adults of the same sex and age. The life expectancies were increased by 15 to 20% in patients who had survived 2 years after starting the antiretroviral therapy. Therefore, South African HIV positive adults can have a near normal life expectancy if they start antiretroviral therapy before their CD4 counts drop below 200. And we know this is the case now. Most people are actually started on ARVs immediately when they are diagnosed with HIV. So is there anything about HIV, aging with HIV in our country? So in 2011, Hontels and his colleagues decided to conduct a study to predict the impact of antiretroviral therapy on HIV epidemic in the population aged above 50 years. They found that HIV prevalence in people 50 years and older will double in the next 30 years, due to reduced HIV-related mortality. And they also find that the fraction of HIV-infected patients aged over 50 years will triple in the next 30 years. So this is also very important for us as psychiatrists because we're expecting that more and more patients will age with HIV. So what are the implications of aging with HIV for the brain? What does it mean? What does it mean for mental health care practitioners? So with regards to HIV and the brain, so the question has always been, does HIV accelerate CNS aging? So one of the severe forms of HIV neurological fallout is HIV-associated neurocognitive disorders. This term encompasses neurocognitive dysfunction due to HIV. It is reported that in the era of antiretroviral therapy, majority of people living with HIV have milder forms of HAND. This is called asymptomatic neurocognitive impairment and mild neurocognitive disorders. Severe forms of HIV of HAND, which is called HIV-associated dementia, is only found in 2% of people living with HIV who are virally suppressed. And the prevalence of HAND, the latest meta-analysis in terms of the prevalence is reported that in 2020, there were about 43% of people living with HIV who are virally suppressed who had HIV-associated neurocognitive disorders. So with HIV, CNS infection being linked with changes that promote neuronal aging, some of these changes that are observed that are associated with related neuronal aging include chronic neuroinflammation, a disruption of the blood-brain barrier, a hypothalamic pituitary axis dysregulation, degeneration of the synapses, increased mitochondrial oxidative stress, and promotion of some of the proteins that are related with neurodegenerative disorders, for example, amyloid beta production and tau hyperphosphorylation as well. So this alone could suggest that if people are aging with HIV, they may be more likely to age earlier, suggesting that HIV can actually accelerate aging, CNS aging. So what are the problems with HIV-related CNS for us as psychiatrists? So one of the things is that we know that with aging, normal aging can lead to serotonin loss, which is often a normal aging process. And unfortunately, one of the most common neuropsychiatric disorders seen in HIV patients is major depressive. They tend to have a high prevalence of depressive symptoms. And in some studies, this has been estimated to be around 30%. And in some studies in general population, they say that these symptoms are only seen in 15% of the population. Like I said, normal aging is associated with a reduction of serotonin neurons and neurotransmissions. In HIV, some scientists have identified that the HIV protein tag can cause reduction in the expression of serotonin genes and serotonin neurotransmission. What is interesting is that serotonin has been found to decrease the HIV replication in human macrophages by reducing the CCR5 expression on the surface macrophages. The CCR5 is one of the receptors that is essential for the cells to actually infect the cells. And another thing of note is that dopamine neurotransmission is disrupted in patients with HIV. And there's evidence that the TET protein causes dysfunction of the dopamine transporter. And when this is disrupted, this can lead to prolonged postsynaptic excitation, which often leads to neurotoxicity and neuronal death. Dopamine neurons tend to be abundant in the basal ganglia, and it has been observed that patients with HIV tend to develop movement disorders earlier compared to people that are not HIV positive. One of the things is that dopamine is also essential for motivation and drive, and lack of this neurotransmitter may result in apathy and low mood. HIV-1 has been associated with an increased risk of Alzheimer's disease pathogenesis. There's been growing interest with regards to this, based on the slide that I've presented earlier on, that HIV can lead to increased amyloid beta production. Ortega and his colleagues in 2020 found that virally suppressed patients with HAND have a higher burden of amyloid beta pathology, but this was lower than when they compared to patients who had Alzheimer's disease. So as much as HAND patients have got higher burden of amyloid beta, but the levels are lower than those that are seen in amyloid in patients with dementia, with Alzheimer's dementia. On the ApoE allele E4 genotype is one of the major risk factors for late onset sporadic Alzheimer's disease. This causes enhanced synthesis of the amyloid beta production. People living with HIV who express this gene have been shown to develop amyloid beta pathology prematurely, meaning that for patients who are not HIV positive, this becomes a risk factor only after the ages of 60. But for those who are HIV positive, they may start developing this kind of pathology earlier. And this is most likely due to the synergistic effect of having HIV, chronic inflammation, and expressing this genotype. Furthermore, ApoE4 genotype increases the risk factor of elevated cholesterol in patients who are adherent to antiretroviral therapy, who are age 50 years and above. This may compound a risk of early neurodegenerative disorders to cerebrovascular accidents. And then what about antiretroviral therapy, aging, while taking these drugs? As I've mentioned before, the prevalence of HAND is still as high as what we saw before ARVs were widespread. But other factors have been found to contribute to this persisting burden of HAND in the ARV-treated patients. One of those factors is an CD4 count, the legacy effects, which is the damage that is caused before the treatment is started. Antiretroviral therapy has been found neurotoxic, so they can contribute to injury and HIV and brain aging. Another concept of cognitive reserve also contributes to this burden of HAND and the presence of comorbid illnesses. With regard to our current first line, which I'm going to talk about, we've got a fixed dose combination, which is often composed of two nucleoside reverse transcriptase inhibitors. It's often TDF and 3TC. And nowadays, we're using the integrase inhibitor, which is dolutegravir. This is now slowly replacing efavirenz, which is an NRTI, but I think efavirenz is still a very important component of FDC because DTG was only introduced in 2018. Efavirenz is reported to have the highest neuropsychiatric complications. We're going to touch on this briefly as we go on. So focusing on individual class of the ARVs that we're looking at. So NRTIs effects on brain aging, especially tenofovir. The mechanism of this drug is to block the reverse transcriptase, which is an essential enzyme for viral DNA synthesis. But unfortunately, these drugs also cause off-target mitochondrial polymerase gamma inhibition, which is an enzyme that is essential for mitochondrial DNA replication. And this may lead to mitochondrial toxicity. And NRTIs have been indirectly linked with development of HAND. And the integrase inhibitors, which is the new drug that is now part of the first line. This was approved, the first one was approved in 2007. And in South Africa, this DTG was approved in 2018. This drug inhibits the integrase protein, which is essential for viral complementary DNA integration into the host DNA. It's got advantages over efavirenz. It's got fewer side effects and low risk of drug resistance. Some of the neuropsychiatric effects that have been reported includes insomnia, depression, and anxiety. And again, the mechanism behind these neuropsychiatric effects has been postulated to be via the mitochondrial toxicity. Effervescence, which is, like I said, as much as it's being replaced by DTG, remains an important drug component of FDC. It's unfortunately the most infamous when it comes to CNS neurotoxicity. It's been shown in animal studies to cause endoplasmic reticulum stress and mitochondrial toxicity, even within the normal drug concentrations. Due to these neurotoxic effects, comparisons of neurocognitive function in patients on effervescence versus PI confirmed that long-term use of effervescence was associated with worse neurocognitive outcome when compared to the other drugs. So being on effervescence may lead to irreversible cognitive impairment. In another study, some investigators switched effervescence to an alternative regimen and followed their patients for 10 weeks. And they found that cognitive impairment did not improve, suggesting that effervescence may have persistent neurocognitive dysfunction. Again, on aging, some of these drugs may also affect the telomere length, which telomeres are found at the end of chromosomes. The function is to protect the genome from nucleotide degradation and interchromosomal fusion. With each cell division, a small portion of the telomere DNA is lost. Therefore, as the length shortens, the cell undergoes senescence, which means that the cells irreversibly stop dividing and eventually may die from this. So telomere length does serve as a biological clock to determine the lifespan of cells. NRTI therapeutic dose, especially the effervescence, has been found to inhibit the telomerase, which is an important enzyme in ensuring that the telomeres renew themselves. They continue to improve their length. And with this inhibition, this leads to progressive shortening of the telomere length. This has been demonstrated in the neurons as well. So this is one of the pathways through these drugs can cause premature aging or promote neurodegenerative disorders. So now going back to Mr. X, what we could have done, what could we do for him? Because he presented as someone who has no history of any illness except for HIV, but then he demonstrated progressive neurocognitive decline, while he was virally suppressed and then compliant to his medication. But of note is that he's got long-term HIV infection and he's been sick for about, he was diagnosed 30 years, but he only started his treatment 5 years later. So that's one of the challenges that we may have with him, based on the fact that some patients will develop injury before they are started on treatment, which is often termed legacy effect. But in terms of what we could do for him, one of the investigations that we could do CSF viral DNA. So we look at the CSF in the viral CSF viral DNA. So we look at the viral load in the CSF. This is often termed CSF viral escape. This is seen has been reported in about 4 to 20% of the patients who are virally suppressed. So as much as they are virally suppressed on the plasma, but they demonstrate elevated CSF viral DNA. And then we can consider one of the things that one could do for Mr. X, if the viral load is high in the CSF, then one could consider doing genotyping the CNS virus to see if it's not resistant to the current regimen. Another investigation that could be considered is to look at the effervescence levels, because effervescence has been found to cause neurotoxicity, and delayed effervescence neurotoxicity has been reported, as much as most of the patients will present early, but some patients have developed neurotoxicity very late after being on effervescence. So these are the differentials. And then so the treatment will obviously depend on the investigations, but what is important is for us to immediately switch him to DTG because that works better. There's less viral resistance, but and everyone is being switched to this drug. So in conclusion, so what then? As people live with HIV longer, we are getting to learn more about the uniqueness of the CNS in the longitudinal cause of HIV. We're learning how the virus behaves in different compartments, and CSS virus can replicate and mutate to strains that are resistant to treatment in the blood compartment. We're learning about the neurotoxic effects of antiretroviral therapy on the CNS and aging with long-standing HIV. So the question is, are we going to see a surge of neuropsychiatric disorders in this unique aging population? There's been a growing interest in the discovery of adjuvant neuroprotective therapies and improving the efficacy of antiretroviral therapy in the CNS. Early studies focus on the antiretroviral CSF penetration effectiveness, so-called CPE, scoring of the drug as a determinant of efficacy, but this has not proven to be the best way of detecting if the drugs work or not. And there's been agents that have been developed that will interfere with HIV-related injury pathways. These agents are being investigated in animal models of HIV. One of the drugs that have been trialed is using memantine, which blocks the NMDA receptors. The hypothesis is that memantine will prevent glutamate neurotoxicity. And lithium has been investigated as another neuroprotective agent. Lithium works by blocking the GSK3 beta pathway, and it also increases the expression of the CNS BDNF. This is the end of our presentation. Thank you, Prof. So this is from the internet. This patient is from Lisbon, and this was published in 2018. And I think the medical doctors were very excited because this was the first patient that I've seen who has lived beyond 100 years. Apparently was diagnosed at 84. So as much as there are issues with ARVs in terms of neurotoxicity, but what we know is that the use of ARVs has improved the lifespan of people that are living with HIV and their quality of life. Thank you, Prof.
Yeah, sure. Thank you very much, Lindor. I thought that was really interesting, and thanks for giving us plenty of time for discussions. So colleagues, this is your time to ask questions. You can either type your questions in the chat, or you can just raise your hand if you can, and we'll allow you to ask Lindor questions directly. I'm going to start, Lindor, and say I find it quite fascinating and interesting, and I want you to just explain it to us a little bit further. This minor cognitive impairments, or people that are on HIV, that have HIV on medication, virally suppressed, and you still find that they have some cognitive impairment. Can you just give us a little bit more on how significant is this? In other words, is it something that kind of affects, if a professional, if they're a teacher and they're working, what are some of the clinical significance of the cognitive impairment? You're on mute, Lindor.
Thank you, Prof, for that interesting question. So the significance, one of the things is that HIV, the so-called HAND, HIV-associated neurocognitive disorders, one of the great thing is that it's not progressive. So if people are diagnosed with HAND, the majority of them will not actually progress to develop the severe forms of HAND, which is HIV-associated neurocognitive disorder, HIV-associated dementia. So that's one of the things that have been highlighted. So as long as you are virally suppressed, you may present with the milder forms, which is ANI and MD, but you may not necessarily progress. With regard to why it's important, so having hand, for example, ANI is quite, it's a debatable entity in terms of how significant this is, because it's an asymptomatic neurocognitive impairment, but these people are functional, they just have symptoms, and it's often based on doing IHDS, just doing the screen, and then later on you say you've got ANI, but the implications of functioning are not very clear. With regard to longitudinal cause, if you were to compare it with maybe MCI in Alzheimer's disease, maybe that's got more clinical significance, because you expect that population, those people with MCI, to progress to Alzheimer's disease. But with hand, like I said before, they don't progress. So that entity is quite a debatable entity. With MND, which is also a mild neurocognitive disorder, obviously those patients have got impairment. They demonstrate some dysfunction in some areas of functioning, for example, at work. So it's got implications in terms of their adherence to treatment. They're more likely to suffer other psychiatric disorders, for example, depression and anxiety. So that entity has got a lot of implication. But there's a lot of work that is being done to revise the hand classification and actually what is it that we're looking for. I hope that answers your question.
Sure, thanks. Yeah, I think so. So it is important, I suppose, in the future. Ketelo, did you have your hand up and then you put it down, or do you still want to say something, sir?
Hi, Prof. Thank you for the opportunity. Thank you very much, Dr. Taylor, for a very nice and presented detailed presentation. It's quite exciting and interesting. You mentioned quite a lot of important things, which are very important that we have to tease out. But I want to ask you to further just tell us more about the telomere race results perhaps that we have in South Africa. Do you have any studies that are related to that, and what thus far do we have, and how then perhaps we can construct our studies going forward? Thank you.
Thank you, Ketelo, for the question. I haven't seen anything in South Africa with regards to telomere length. So I think your question is quite interesting. I know that you're coming from a background of neurosciences, so that's something maybe worth exploring, looking at our population, because we have the highest number of people that are living with HIV in the world. So maybe it's something worth exploring, but I didn't find anything on telomere length in our population and the effects of antiretroviral therapy on the telomere.
Yeah, no, thanks, Lindor. Mahlubonke Shwati.
Thank you for this initiative, and thank you for Dr. Taylor for this presentation. It's quite an interesting presentation. But a few questions, just a couple of questions. So one is the issue that, like most of the patients, the entry of HIV into the CNS occurs early during acute seroconversion. And probably that would result into asymptomatic neurocognitive impairment. What tests can you do to pick up the tools to which you can use to pick up the asymptomatic neurocognitive impairment in these patients? Because they are functioning normal, they keep on functioning, and then when you start on ARV, but the thing is, you'll find that they do have some mild asymptomatic neurocognitive impairment. The other question is because you've mentioned that with the dopamine loss, most of these patients, they tend to develop movement disorders. What movement disorders do you commonly see in these patients apart from apathy? which you've noted in these patients. And the other question is the use of tenofovir, because I mean, like you're saying that tenofovir has got mitochondrial toxicity, and which can cause the effects of on the neurons and neuronal degeneration in these patients. And it forms quite a big bulk on most of the patients on ARVs. I mean, like it's one of the backbone of the treatment in these patients. And are we seeing a lot of these patients with neuronal degeneration since they've been on tenofovir because most of these patients are on tenofovir for quite a long period of time? Okay, thank you.
Hlubi, you must also just first introduce yourself and tell us that you are a neurologist, so that we know who we're dealing with answering.
Sorry, I'm a neurologist at Inkosi Albert, literally. Thank you.
Thanks, Hlubi. Lindor?
That's a lot of questions, Dr. Kwati, but I hope I remembered some of the questions. So I think one of the questions was regarding the profile of movement disorders that we see in patients with HIV. I think that was one of the questions. And the other question, you were saying that about neurodegeneration related, if we have seen patients with neurodegenerative disorders related due to tenofovir.
Yes.
What was that question?
The tools which can use to assess those patients with asymptomatic neurocognitive impairment.
Okay. So in clinical practice, so we often use the International HIV Dementia Scale, which is a screening tool, and based on those findings, then you can decide. But obviously, with ANI, the theory, the diagnosis is based on the fact that the patient has got symptoms, but they do not have functional decline. But you can supplement that because of the profile of the cognitive domain. So IHDS does not actually cover all the domains. So you can supplement with that with, for example, MOCA, because IHDS does not pick the dysexecutive function. So in most cases, one would have to combine those two tools, at least those tools, because the idea is that HIV does affect your subcortical, what we used to call subcortical neurocognitive disorders. In terms of the movement disorders, this is now based on the pathophysiology of HIV. So, but one would then, in theory, suspect that if the HIV tends to affect your basal ganglia, then you would expect that these patients will present with movement disorders that result from basal ganglia dysfunction. Those would be your Parkinsonism, your tremors, those signs that are representative of the basal ganglia dysfunction. With regard to tenofovir neurodegeneration, so this is based on animal studies. Like I said, I don't think anyone has actually done, I haven't seen anything done in human beings where people have actually explored the effects of tenofovir in human tissue or human cells or telomere for that matter. So most of the literature on HIV actually comes from animal studies. So I haven't seen anyone, and I haven't seen any study that has been done to explore if these drugs actually cause neurodegeneration in human beings. But again, that's something that is interesting that people who have interest in neurosciences could explore. Thanks, Dr. Taylor. I hope I've answered the question.
Lindor, I just wanted to ask you, I mean, the marker comes from Canada, and I don't know where the IHDS comes from, but isn't there, I thought John Joska didn't like those and wanted to have his own scale where he used some things that were a bit more sensitive.
Yeah, but I think people have tried to actually see if MOCA could be, was appropriate to our culture. People have developed MOCAs. I know there's a MOCA in Afrikaans for Western Cape. I'm not sure about any MOCA that is, but it's true that MOCA has got its own limitations in terms of being relevant to our context, in the context of people. And I know there are scales that are being developed to actually try and see if they can pick the same amount of cognitive dysfunction that is picked by the MOCA.
Sure. Okay, thanks, Lindor. I'm going to move to neuroscientist. Tabby, do you want to introduce yourself and ask your question?
Hi, Prof. Thank you. My name is Tabisile Mbofana. I am in physiology. My interest is in neuroscience, neurodegenerative disorders, and neurodevelopmental disorders. Thank you so much, Dr. Taylor, for the talk. I found it very, very interesting. Now, one of the things that you mentioned is in the pathophysiology of how the HIV enters the brain is the activation of the microglial cells. Now, inflammation is shown to be one of the main driving forces in neurodegenerative disorders. So I'm just wondering, with our current treatment methods, is there anything that we have in terms of reducing the inflammation? And also with HIV patients taking their ARVs long-term, I'm wondering if that doesn't have any effect on maybe their trace element status, and because I think maybe that would cause problems along the way. And so whether there is, do you then prescribe, you say if you take this medication, you should also consider taking food supplements and whatnot. So that's where my mind is around.
Thanks, Tabby. Can you repeat your second question, please?
It was around oh, sorry, Tabby, go for it. But basically, she was asking if there's supplements that could help that are anti-inflammatory that we could use. I presume, Tabby, you've got some candidates in mind, right?
Just thinking about it.
Okay, thanks, Tabby. So I think, yeah, so one of the ways that people have been, scientists have been exploring in actually trying to improve CNS function in patients with HIV, like highlighted that they tend to present with chronic neuroinflammation despite being virally suppressed, is looking at agents that are neuroprotective. GSK 3-beta being one of the pathways that is also involved in promoting neuroinflammation. So some people have tried to explore that pathway by introducing GSK 3-beta inhibitors, for example, lithium. And then there's a lot of evidence that lithium actually improves neuroinflammation. So that's one of the treatments that people have explored. Beyond that, I haven't seen anything in literature other than GSK 3-beta, but I can imagine there's so many approaches that people have explored in trying to improve or reduce neuroinflammation in patients with HIV. With regards to nutrition, yeah, that's a big question for me. But I think obviously there's always a role. I mean, if you think of the oxidative stress that we often say these patients have increased oxidative stress. So nutrients, some of the vitamins, for example, have got antioxidant effects. So maybe approaching it along that pathway, there's a role of that pathway actually improving nutrition and encouraging patients to have meals that are loaded with antioxidants. I'm not sure about other oils that have been used in the past, for example, that are neuroprotective, but I can only think of antioxidants at this stage. I hope that answers your question, Tavi.
Thanks, Lindor. Can I move to Dr. King, Laurel, psychiatrist?
Thank you, Bonga. Thank you, Prof. And Dr. Taylor, thank you for such a beautiful presentation. It was excellent, well done. And I'm so pleased to see that you're back in the province on our soil. You alluded to the fact that in the age group 50 plus who are living with HIV, they have an increased incidence of developing Alzheimer's type dementia. You also said that one of the agents, especially in your patient X, one of the possibilities in his case would be memantine. If there is a trend where we will now be seeing more as people age and live longer with HIV because of the success rates of ARTs, we will be seeing more people over the age of 50 with cognitive problems. And they are very economically active still, at least until the age of 60, 65. And they in that subgroup who you define as cognitively impaired, but still functional. So we want to try to keep them functional and try to minimize and slow down the cognitive impairment. I know you've spoken about all the various ARVs, etc., which is not my domain. I'll leave that to the physicians. But is there a place for us to start things like memantine earlier rather than later so that we can preserve functioning, where you say there's early cognitive decline from your screening, etc., but they're still functional? And even though they're still functional, would it be appropriate for us to introduce memantine earlier in the hopes of preserving their functioning for as long as possible, because they are still a very economically active population?
Thank you, Dr. King, for that question. So, yes, yeah, the amyloid pathology has been identified in some of these patients who are HIV positive, but what is actually the load or the amount of amyloid pathology tends to be less than what we see in patients who subsequently develop Alzheimer's disease. So as much as the pathology has been found, but it's not convincing that actually having HIV alone is a risk factor for developing Alzheimer's dementia. So it's just that they tend to have the pathology. For patients who are well suppressed, who are taking their antiretroviral therapy, the evidence is that they will express the amyloid pathology, but not to the extent to that is expressed by patients with Alzheimer's who eventually develop Alzheimer's disease. With regards to memantine, the current evidence suggests that memantine has no role in treatment is ineffective in treatment of hand. I think that the reason behind that is the fact that, so one of the things is that if you were to consider using it in someone who has ANI, for example, asymptomatic neurocognitive disorder, the current literature indicates that as long as your patient is virally suppressed, they're taking treatment and they do not have comorbidities, they tend not to progress. So as much as they demonstrate the signs or symptoms of ANI, but HIV hand is not a progressive neurodegenerative disorder when it's treated correctly. The problem with hand is that most of the patients, by the time they start treatment, the damage has already been done. So what we call the legacy effect. So when they start treatment, most of them have had severe damage to the brain, like Swati has elaborated on that HIV tends to affect the brain or infect the brain very early after seroconversion. So by the time they are treated, they may actually have already developed evidence of ANI, but most of them may not have been screened. It's only on screening that they may find that they've got this. But another thing is that the concept of CNS viral escape, which I think becomes very important, especially now that we know that the virus may be resistant to the treatment. So exploring that avenue, I think is very important before you start thinking that this patient is progressing because of HIV associated neurocognitive. There could be another aspect to it. So memantine is not effective. I think, again, it's because there's so much happening in the brains of HIV and people living with HIV. It's not just the glutamate neurotransmission, but it's all the neuroinflammation that is happening and dopamine neurotransmission. So it's just a complex neuropathology, not just the memantine, not just the glutamate.
Fair enough. So where is the place then? So at which point or under what conditions would you recommend introduction of memantine then?
Okay. So I wouldn't recommend it.
Because it came up in your slide about Mr. X.
So these are, so in that slide, I was highlighting some of the neuroprotective pathways that have been explored. So
okay.
One of them is, most of them actually have not proven to be effective. Memantine was not effective. Lithium, there's very limited evidence that is actually effective. So we're still in the dark, to be honest.
So
Thank you,
I'm
Dr.
really,
Taylor.
really sorry, colleagues, Laurel, sorry, Lindor, but I just want to say thank you so much. We have run out of time, unfortunately. I'm sure Dr. Taylor will be happy to answer more questions. His email address is taylorl@ukzn.ac.za. We probably need to set a little bit more time next time, Basil, to this. But thank you, colleagues, for a wonderful first seminar. Next month, Basil, I'm hoping that we are going to be having a neurosurgeon, star neurosurgeon, who's going to be talking to us about functional neurosurgery. Is my right, Basil?
Yeah. You're right. Yes. Looking forward to that. But thank you. It's been a great start to the lecture series. Well done, Dr. Taylor.
Thank you so much. We have to jump off now and move on to another meeting, so appreciate it. Thank you.
Prof.
Thank you. Bye.
Okay.
Bye.